And I wanted to start off by giving kind of an overview of the complexity of pain and all the different factors that contribute to an individual's pain experience. The nervous system is a primary player in that process with its role in kind of modulating input and various other factors that include our thoughts and our emotions. So there's quite an extensive literature base over the last many years that indicate that negative thoughts and emotions such as catastrophizing, fear of pain, depression, and anxiety can certainly have an effect that amplifies one's pain. And in contrast, so people who are kind of happier, more optimistic, have more positive outlook on life tend to have a lower pain experience. It tends to have a protective effect in terms of pain. There's obviously, of course, people's genetic backgrounds, as well as kind of family history, which I would refer to kind of more the nurture side of things. So, for example, in our formative years, it can the stresses of lower socioeconomic status, for example, can impact one's pain sensitivity as an adult. And then, of course, finally, we have disease processes such as osteoarthritis, which we know pain is a prominent feature of. So I thought I'd just spend a moment talking about how we process pain. And this is kind of a simplified schematic to start here. So basically, we have some type of stimulus that gets introduced to our environment or to our tissues. This creates kind of noxious stimuli that enters our nervous system and travels up to our brain. And our brain then takes that information and combines it with information such as our past experience, our beliefs, our culture, and synthesizes that to make a decision about whether we need to be protected. And if the answer to that question is yes, then that typically results in the experience of pain. And pain, of course, can then alter our behavior. We might limp, we might guard our limb close to our body, and as well, we might have changes in our physiology. It could spark an inflammatory process, muscle spasm, etc. And all of this gets fed back into the nervous system and kind of continues as this ongoing feedback loop. So if we look now a little bit closer at what's happening in the nervous system, and I'd like to thank Sahina Niyoji for use of this image. We see here we have a knee joint with nerve endings, and we have nociceptors in those nerve endings that are typically in OA stimulated by both mechanical and inflammatory factors. And they will send signals up into the dorsal horn of the spinal cord, where they will enter the central nervous system and then ascend to where they can be modified in the midbrain and ultimately end up in the cortex. And again, here we see kind of integration of this information. And then we get descending signals that can be both facilitatory or inhibitory. And basically, we have this process whereby there's this kind of ongoing tension, if you will, between what's coming up and what's going down, and that ultimately decides on the pain experience and quality of that experience that an individual has. So we also know that, unfortunately, there can be dysfunction that develops in this system. And this is often referred to as sensitization and happens usually due to chronic and continuous nociceptor stimulation. And that can affect both the peripheral nervous system, and this is referred to as peripheral sensitization. And it typically results in primary hyperalgesia. And then in the central nervous system, we have central sensitization, and this mainly results in secondary hyperalgesia or spreading of pain into other parts of the body. And so basically what happens is we get a stimulus that could be not painful at all, that all of a sudden is creating pain, and this is referred to as allodynia. or other stimuli that were initially mildly painful and are now quite painful, and this is hyperalgesia. Bottom line is that we have a system that is now more sensitive and more reactive, more labile, much more, creates the pain experience much more easily. And it's important to note that this can happen in the absence of tissue pathology. So how do we measure modulation of pain? I'm going to focus ultimately on exercise-induced hypoalgesia over the next few minutes, but wanted to just highlight these two methods that are typically used. So exercise-induced hypoalgesia is a reduction in sensitivity to painful stimuli following exercise. So typically we will use some type of quantitative sensory test like pressure pain thresholds, initially get a baseline value, then have a person exercise and then take those measurements again. And if everything's intact, then we see a reduction in sensitivity to that stimuli or an increased tolerance to it. And then conditioned pain modulation is not specific to exercise, but it is a test that indicates the functioning of our endogenous pain modulating system. And it uses a paradigm of pain to inhibit pain. So we typically use what we call a test stimulus at a lower intensity, followed by a conditioning stimulus at a higher intensity. And this, if CPM is working well, it will serve to inhibit that test stimulus. We apply that test stimulus a second time after the conditioning stimulus. If it's working efficiently, we'll see again an increased tolerance or decreased sensitivity to that. It's important to note that EIH and CPM appear to have overlapping functions. This isn't fully understood yet, but we have seen that function of one tends to impact the effectiveness of the other. A study by Singleton in 2015 showed that in those with knee OA and impaired CPM, they had a lower EIH response than those with intact CPM. In terms of mechanisms of EIH, there's theorized that multiple systems are involved. Most of this work has been looked at in healthy individuals, and there's been limited study of people with chronic pain. The most studied has certainly been the endogenous opioid system, and then others include the endocannabinoid, serotonergic, immune, and autonomic nervous system. And then other areas that have been less studied, but which we know that there's potential for differences there include sex differences. Certainly there's lots of evidence to say that men and women experience pain differently, and there is some evidence showing that women might have a stronger EIH response than men. And in terms of psychosocial influences, interestingly, in healthy pain-free participants, we've seen that again, our thoughts or emotions do seem to impact the EIH response, but interestingly, in the chronic pain literature, so far, this does not seem to be the case. These factors are not having any impact on the EIH response. But again, the base of evidence here is small. So I thought it'd be good to get a kind of a baseline of what EIH looks like in pain-free adults. It's typically observed pretty much after any intensity of exercise, but the higher the intensity, the better. There's been a few different systematic reviews of this area, and they have different results about the type of exercise, which is better, aerobic versus resistance, which also includes isometric and dynamic resistance. And the main reason thought to be behind this is because the methods of testing that people use for EIH are quite variable, as well as the actual parameters of the exercise that they're using. And so this is certainly an area for standardization. In terms of the effect, we see that it lasts up to 30 minutes. It doesn't seem to differ by age. Like I said, it's potentially stronger in women. It's dose dependent, so more is better, also in terms of frequency. And then more pain provides more relief. And by pain here, I'm not referring to joint pain, but I'm referring to the pain of related to exercise itself. And regular exercisers have a better effect than people who are inactive, although they still do see an effect. The greatest effect is seen at the body part that is being exercised, i.e. local versus more remote parts. Also it's important to note that the effect is impacted by one's expectation around exercise and pain, as well as messaging that we might receive from others around that. And so now turning to the effects of exercise of pain sensitivity, both in OA and other chronic musculoskeletal conditions, we see that greater baseline sensitivity or sensitization and or impaired CPM leads to a lower hypoalgesic response. And this has been shown in people with knee OA. And we see that when non-painful sites are exercised, the EIH response is more intact and stronger than when we measure it at painful sites. Again, this is a study of people with knee OA that looked at upper body exercise versus lower body exercise. But we do see that there's inconsistent findings by the type and intensity of exercise. So again, kind of a mix in terms of whether resistance is better than aerobic. And for some people seem to respond better to medium or moderate intensity versus high intensity. The other thing to notice is that there's just varying responses depending on the type of condition that's been studied. So people with shoulder, low back, or low back pain, as well as hip and knee OA have experienced relief after exercise, whereas multiple studies in people with whiplash have shown no real change in response to exercise. And finally, in those with fibromyalgia or chronic widespread pain, we see a hyperalgesic response to pain, so more pain. And then lastly, looking at EIH specific to OA, and this is really specific to the knee. There's been a systematic review about this, and really where the majority of the evidence lies. There's been another study on a mixed group of hip and knee OA. But after one bout of acute exercise, the only effect was seen locally using pressure pain thresholds. They found a significant effect, but there was no difference in the type of exercise that elicited that, and no other differences were seen in the other aspects used there. And then if we look at exercise programs, they varied from 5 to 12 weeks. And basically no differences were seen across any of the measures, sites or types of exercise. So in summary, we have not a precise understanding of the mechanisms of pain relief after exercise, but we do see that EIH in people with chronic pain do have similar but distinct effects than pain-free individuals. We do see in people with OA that exercise decreases sensitivity of the nervous system, and we see this more at local joints that are being exercised compared to remote, but as well as pain-free sites more than painful. And future research directions in this area would benefit from addressing standardized protocols for testing of EIH, as well as administration of the exercise type and dosage to determine what might provide an optimal EIH response. And as I said, there's kind of been a limited understanding of cognitive and emotional factors on EIH, certainly in people with chronic pain, and certainly there's, from what I've seen, there hasn't been any work on this in people with OA. So that's another area that would be interesting to develop.